In this video, we are going to present a case of a 55-year-old obese patient with several comorbidities. In the preoperative CT scan was detected a 60 mm lesion on the 8th segment, suspected either for ACC or cholangiocarcinoma. The use of 3D CT scan reconstruction and the liver vitro resection is routinely performed in our center. As you can see here, the lesion gets 9 mm far from the middle hepatic vein. After calculating the future liver remnant, in our multidisciplinary discussion, we decided to do an intraoperative biopsy of the tumor. In case of high suspicion for ACC, a right hepatectomy would have been performed, while on the contrary, in case of high suspicion of cholangiocarcinoma, a portal vein embolization will be performed with a subsequent extended right hepatectomy. After the intraoperative biopsy, the frozen specimen sent for analysis identified an high suspicion of ACC. In this case, we decided to perform a right hepatectomy. Firstly, we start with a complete mobilization of the right liver, dividing the right triangle ligament, as you can see here, and subsequently, after dividing the falciform ligament, we complete the mobilization in order to permit a complete rotation of the right liver. After that, we start to approach the hilum, identifying the major vascular structure as the common bile duct, and subsequently the right hepatic artery, both of them encircled with a vessel loop in order to expose the right portal branch underneath of them. Before dividing the right hepatic artery, a clamping test with a bulldog has been performed. After that, the right hepatic artery is divided between clips. Finally, we identified and isolate the right portal vein. Before dividing the right portal vein, we are used to perform an ultrasound checking on the left liver in order to evaluate the presence of a portal flow on the left liver. After that, the right portal branch has been divided between clips. After a deep ultrasonic assessment of the tumor relation to major vascular structures and especially to the middle hepatic vein, the key structures are marked with diathermy on the capsule, and with the help of ICG green, a correct transection line along the so-called Cantor line is painted on the surface of the liver. Here, as you can see, with the ICG green help, the liver demarcation is stressed. After that, we start the transection. In our preoperative plan, the middle hepatic vein should be preserved and exposed on the liver surface of the remnant liver. After the resection of the Spigelian lobe, the right hepatic duct is identified, isolated, and ligated between clips. After that, the distal branches of the middle hepatic vein are identified. And the right one is ligated between clips. Subsequently, we followed the middle hepatic vein exposed on the surface in order to follow a proper transection line. Here you can see the vena cava exposed underneath the liver. Finally, you can see the middle hepatic vein and the vena cava exposed. Finally, using a sort of hanging maneuver, we encircle the remnant liver to be resected. Here you can see the last part of the Macucci ligament. Finally, we use the vascular stapler to divide the right hepatic vein. Here you can see the shape of the right hepatic vein and the middle hepatic vein together. In the end, the operative time was 390 minutes, the intraoperative blood loss 300 cc. The histology detected an ACC poor differentiated with an R0 resection from the middle hepatic vein of 10 mm. The length of stay was 8 days with no major complication. Thank you very much for your attention.